Hi, everyone. They say a picture is worth 1,000 words. But what about a memory? A memory is priceless. And today, the highlight of today's conference is the much-awaited Dr. Sunil Agarwal Oration, the very first Dr. Sunil Agarwal Oration. So may I now call upon the stage the dignitaries. As I call upon your name, may I request you to please come on stage. Dr. Harinder Singh Bedi, the President of VAI. Dr. Indra Agarwal, wife of the late Dr. Sunil Agarwal, Professor and Head of Division of Child Health at CMC Vellore. Dr. Saravanan Sundarraj, founder member of VAI and Director of the Vascular and Transplant Unit at Madras Medical College. Dr. Sanjay Desai, Secretary VAI, Dr. Gulshanjit Singh, Treasurer VAI, Dr. Roy Verghese, Chairman of the Governing Council of VAI, Dr. Deepak Selvaraj, Vice President of VAI, I now request Dr. Prabhu Prem Kumar to welcome the gathering for this very first Dr. Sunil Agarwal Oration during YCon 2022.
Can I request those who are on the back to please fill up the seats? Thank you. How do you honor someone who's held your hand, who's taught you to take the sutures right? How do you honor someone on whose shoulders you built your career, your life? Sunil stood for everything that is good here, as a fond memory, as a friend, as a mentor, as someone who will call a spade a spade. It is indeed my privilege to welcome you all for this, the very first Sunil Agarwal Oration. I hope each of you will relive the memories of Sunil, for he always is in our hearts.
For this oration, the citation reading will be done by Dr. Saravanan Sundarraj. Over to you, sir.
Good morning, everyone. Sunil was a very good friend of mine. 7 of us, including Sunil, started this association 15 years ago. In fact, the first meeting was held at CMC Vellore among 7 of us. I am really proud to stand in front of you, and I'm sure he will be proud wherever he is watching us. Dr. Sunil Agarwal Oration is established by the family, especially his parents, Mr. Pawan Kumar Gupta and Mrs. Pushpavalli Gupta, in partnership with the Venus Association of India, to perpetuate the legacy of Dr. Sunil Agarwal. This oration seeks to honor extraordinary surgeons who present the passion, integrity, and human nature of Dr. Sunil Agarwal to inspire other surgeons to emulate commitment to excellence with compassion. Dr. Sunil, former professor and head of the vascular surgery, joined the Christian Medical College, Vellore in July 1978, after graduating from Doon School, Dehradun, and DAV College, Chandigarh. Armed with MBBS and MS in general surgery from prestigious CMC, Vellore, he took on the role of faculty and surgeon with diligence and compassion. Subsequent to his training in vascular surgery at Queen Elizabeth Hospital, Adelaide, Australia, he was instrumental in starting a one-year fellowship vascular surgery program at CMC Vellore. He excelled in his leadership roles as professor and head of the general surgery. The Department of Vascular Surgery went from strength to strength during his leadership. The foundation for endovascular training was laid by him, and his team now stands tall on his shoulders. As a senior vascular surgeon, he was an active member and office bearer of both Vascular Society of India and Venous Association of India. With a primary focus on patient care and passion for teaching with high standards, Dr. Sunil Agarwal believed in extending services to the mission hospitals in the true spirit of CMC, not to be ministered unto, but to minister. A champion for poor patients, he walked an extra mile for many, not by demand or enforcement, but by demonstration of influence, seemed to be his personal motto. He was instrumental in personal and professional development of many who are excelling in vascular surgery now. Throughout his illustrious career, he taught, trained, mentored, and inspired young surgeons. His unassuming, selfless, humble, kind, non-judgmental, excellent life of leadership with a healthy balance in personal and professional life has left a beautiful legacy for all vascular surgeons. To honor his exemplary life and service, we are delighted to present the first Dr. Sunil Agarwal Oration to Dr. Devendra Dekiwadia.
Thank you, sir. It is indeed an honor for us today that Dr. Indra Agarwal is here with us. May I now call upon Dr. Saravanan Sundarraj and Dr. Roy Verghese to honor Dr. Indra Agarwal, who is here with us on this very first Dr. Sunil Agarwal Oration. Thank you, Dr. Indra, Dr. Saravanan, and Dr. Roy. We go to the highlight of this program, and that is the Dr. Sunil Agarwal Oration. And to introduce to us the speaker, we have Dr. Sanjay Desai, the past president of VAI. Over to you, sir.
Morning, everyone. It's indeed an honor to be associated with two great people. One, of course, Sunil, who we all have fond memories. He was a wonderful host, and the less said, the better. So, but it's an honor that we institute this, and we have the family with us to have the first oration here. Talking about Dekiwadia, I think the first thing which came into my mind when they asked me to introduce, Dekiwadia comes from the region in this country where when we ask people, Kemcho, they say Mazama. You know, literally means, how are you? It's the immediate reaction is, I'm happy, or I'm joyful, or I'm wonderful. It's the kind of people, that's the region he comes from. And he emboldens that with his presence. So it's my honor to introduce him. We all know him as a cardiovascular surgeon. Few things which we don't know, which I shall try to put it up, is he passed out from PGH Chandigarh. He worked at Jamnagar Medical College. He went up to the post of associate professor, and then went on to set up the Dekiwadia Institute of Vascular Sciences. He's got tremendous interest in terms of cardiac cases. He's done about 3,000 heart surgeries, about 2,000 thoracic surgeries before going into vascular work. He's a pioneer in heart surgeries in Saurashtra, in Rajkot, and he has established the state-of-art center, including a vascular cath lab in Rajkot. Some of us who are at Rajkot for one of the conference which he organized will fondly remember the quantity and the quality of work which is happening at Rajkot, and it was all due to this man's effort where he has taken vascular and venous work across the country. What we know him as a surgeon, I think what we do not know him as a person, we all are passionate about a lot of things other than our work. You know, a man is recognized not by the profession, but what he does beyond his profession. We are all passionate about doing a lot of things, but he's somebody who's done that. He's an artist trekker, which I have personal interest in, and we share some common interests. He's been traveling across countries. He's traveled across 68 countries. I think most of you here will say, I have done more than that. But what he has done is he has traveled on his own, self-driven. So he loves driving. He drives across countries, across borders. He's visited all the borders of our country, spent time with the Jawans. What we see nowadays on the TV channels, you know, a lot of filmy people going up and spending time and showing it. He has been doing this from years before, you know, anybody thought of doing this. So he has spent most of his time with the Jawans at the borders, which is tremendous. Like I said, this is a passion for most of us, but he has been doing it. He is into farming. He loves farming. You should spend some time with him to realize the amount of work and the knowledge he has about the fauna and the flora in the country. And it's very encouraging to see that he has time, apart from establishing a vascular center, doing so many professional work, and he still finds time to do this with the family. Like I said, he's contributed enormously to the society. He has held various posts. He's been the past president, chairman of the Governing Council. The most important contribution from him and for the sustenance of VAI has been he's put it into order. He's got a system organized for the functioning of VAI. He has made a permanent office, we have a secretary, and we have a process in place. So I think the credit goes to him for having set up and has the VAI established so well. He is now contemplating, or I don't know if he's already finished, he is writing a book with the motto, "Youth Never Dies," and I think that personifies what we see in him and the way he comes across when you meet him. And it's wonderful to know that this book is going to come across. I don't know if it's come or he's in the process, but that will be a wonderful read. Again, sir, it's an honor to have you, sir, and may I call upon you to deliver the Sunil Agarwal Oration. Over to you, Dr. Dekiwadia. Thank you.
Thank you very much for that wonderful introduction you gave. I want to share my screen. So let me share the screen first. Am I visible? Am I audible? Can someone put this on the full screen?
To the speaker, requesting
Yeah.
you to put yourself on the full screen. The control is given to
Yeah.
you.
Now, the side panel is hiding me and preventing me. Am I audible? May I
Yes, you
know?
are. Could you
Can
please
someone
try
answer?
now? Give us a moment.
I stopped sharing. No, I'm no, I'm here. I'm here. Yeah. I hope I am audible. Good morning, everybody, and good afternoon from Australia. It's just a coincidence that Sunil studied over here, and today I'm delivering this little talk from Australia. Thank you very much for those kind words, Sanjay. I hope I stand to do the same. I would, like all of us, wish that it would have been a pleasure that Sunil was a delegate listening to this talk. It is difficult to accept that this talk is in his memory. Anyway, life goes on and it has to go on. And so all of us have to. But as I talk, his face comes in front of me. His smile is as it was when I used to meet him, and when I saw his family, I thought I must meet. Unfortunately, I had to be in Australia by 15th of March. Otherwise, I would have been sitting there with you all first. The YCON 2022 theme is research and innovation. And we have to think in terms of what research and innovation has to come into the venous diseases. And it's very interesting as we go on. First, research and innovation comes from the art of observation. And as you observe, and the observation get converted into thoughts, and the thoughts provocate observation. And this cycle continues. And as you record this observation, finally, it leads to a search. And this search results into a research or innovation which we publish. Painful knee and ankle with varicose veins around were studied and published. 1956, 62, 65, 72 and 2001, and then forgot. But then a recent paper has revoked the observation by our friends. These are the veins around the knee joint. You can see this huge one popping down here, this part, and the vein which are concentrated around the knee. And the person, that the people, the sufferers, they had painful knee. So this observation around the knee and ankle, see this complex drawing over here. And the final outcome, look at the toes, what has happened to the toes. This led a thought that it could be a perforator doing something or something this or that. But then the MRIs, when they were studied, and the posterior and middle tarsal subtalar joints were assessed, analyzed thoroughly, and inflammatory arthritis was detected due to these veins. And our friends Roy Varghese, Malay and Manjusha, they made a clinic-based Indian experience of phleboarthritis in a study of 197 patients. A direct association was found between severity of the chronic venous disease and osteoarthritis. Early treatment of CVD could prevent the dysfunction of the knee joint. Phleboarthrosis is a real condition, and its recognition assumes greater importance with increase in life expectancy and lifestyle expectation. So let us look 1956, 62, 65, forgotten, but again brought to the notice in 2020. This is a very, very popular picture. Everyone sitting over here doing vascular practice, venous practice, doing sclerotherapy. There's nothing new in this picture. But till someone got an idea that this winged cannula, what we call a butterfly cannula, if that is used to inject sclerogens into the superficial veins, as we have to keep the needle as parallel to the skin as possible, this small idea worked wonders, and it went into an innovation. Here is one more example. Stability of foam when we do sclerotherapy. This is our day in, day out problem. In a short while, the stability of the foam goes away. So there are new foams coming in. Oh yes, there is a big research going in France, where you will be having a foam which will look not unlike that of a lather, which is made, with the help of a shaving cream. But till then, this was a little bit of an experience. 3 drops of Contrapac, that dye, NGO dye, mixed with the saline and the sclerosant would stand 4 times longer than when this was not added. So small things which come to our notice, we should bring to the notice of our own brethren, and we should also bring forward for the world to know. We very often see, when we see an ultrasound study, the source is unknown. There are varicose veins, and the ultrasound study says that the great saphenous vein and the short saphenous veins are non-refluxing in the entire length. That they can see the perforators which are incompetent, but these perforators are no way connected with the venous bunch which is visible. Then what do we do? The source is unknown. Where are these veins coming from? And I am sure everybody sitting in this hall and those on the virtual platform have faced this at least once in their practice. So here we go. This is a vein. The source is unknown. What to do? Yeah, we can inject a sclerosant, and a beautiful paper this morning we read about the YAG laser Rahul presented. It's so wonderful. Yes, we know the cosmetic component of this. These veins will go away, but soon newer ones will come up unless we know why or what is the source. There is another example of such type of a huge veins, neither related to the great saphenous vein nor to the short saphenous vein, somewhere coming out, jutting out from the posterior lateral aspect of the thigh and spreading right all the way across the thigh, the knee joint and the thumb. This is another beautiful example what we have, gravity and reflux fanning down. So we can assume that there is something wrong here, and with gravity all these veins are becoming the grunt and bearing the grunt, and this is why there are superficial varicosities seen, what you call as a spider vein and telangiectasia or anything else. But when the anti-gravity fanning is there, why this happens? It's very easy to treat. Oh yes, patient will be here from morning, evening, go on home. But no, why there is an anti-gravity fanning? So this thought and observation went on and on in search of a source. We planned varicographs and found some very interesting observations. Let me share a few of these observations with you. This is case 1. Lateral veins, multiple extensive on the left lower extremity, right extremity spared. Commonest thinking is ovarian vein reflux, or another thinking could be that this is the lateral venous plexus, the congenital anomaly remaining, blah, blah. But then when we did the varicograph, we found out a component. This is how the veins were draining. The ultimate vein, this vein was going into the hemiazygous vein. And as we traced it further near the diaphragm, and then when in the cardiac area, it went into multiple vertebral veins before finally draining into the right atrium. And the deep veins, they were normal. There was nothing wrong there. So was it something, some pressure generation? Was it that back pressure which resulted into varicose veins? What it is, that was the question. Case 2. Here you can see there are veins, very small, and we name them popliteal fossa veins, and otherwise everything is found normal. But when we did an angiogram, there was no history of deep vein thrombosis. This much portion of the popliteal vein was missing. And as we injected, we could see all this. There is no further reflux down in the tibials. And then these veins are draining straight into the P3 segment of the popliteal vein and the superficial femoral vein. So here, why this is, what had happened? Is there an injury? What it could be? Only a local segment missing. Why? This why is where we stop. This case which I showed just now, and you can see this portion is somewhere there is a ring-like varicose vein. So this could be the source. Now what's there? What's wrong there? So we made an injection in that ring-like, and yes, this is an obvious picture. There's a lot of varicosities which you see. Well, that's nothing new in it, and that's the question is, what is the need of doing all this thing? We could have just injected or hooked them out. No. As we studied, we found there were two superficial femoral veins. One was looking pretty normal, pretty smooth, nice. The other one was looking little odd. And in these pictures, we found out outpouching of the valves. And there was some disease in the deep vein over here, which was leading to development of the varicose veins. So, in all these cases, whatever I am showing, the GSV and SSV, normal, non-refluxing in the entire length, but yet there are varicose bunches, and then where do they come from? In this patient, very simple, we could see this bunch over here, clinically very easy to recognize, and then with the help of ultrasound, very easy to trace around. However, as we took a varicogram, we found out that there were multiple channels and all were arising from the junction of the common iliac vein and the external iliac vein. It was this point from where there was a back pressure which was created. Why was it created from there? Any pelvic pathology? No. Abdomen ultrasound? Normal. Any history of any surgery? No, nothing. Nothing was there. So as we look into these cases, here, this picture I had shown you earlier. Now let us see this varicose bunch over here. When we did a venogram, there was very interesting observation. The popliteal vein was quite normal. It was draining well. There was a large draining channel over here. This is all very easily understandable because there could be a large channel, and these we can label as perforators and so on and so forth. But this is what is important to observe, that in a very, very short distance, you can see the number of valves. So we counted them. There were 1, 2, 3, 4, 5 valves in this very small segment, and that each valve was probably causing a pressure. Was it causing? Why was it causing? What about the calf pump? These valves should be helpful. None of them were incompetent. Yes, they were all normal, but they were causing these varicosities. So we are again, there is a why, and we don't have that answer. A chronically swollen thigh and varicosities. And the varicogram showed that these veins were draining into the vertical group of lymph nodes. So when this vertical group of lymph nodes, yes, Professor Wool has demonstrated it very well in his anatomy atlas, a wonderful atlas, where you can see that the source of reflux could be these chronically inflamed lymph nodes. And they result into not only varicosities, but they do result into a swollen thigh as well. Now, seeing this picture, anybody would say, oh, yes, this is a post-thrombotic and this vein is draining on the other side and all that thing. No, my dear friends, no history of DVT. And if you see both these veins, this one normal and the other one normal. Bilateral, external iliac, common iliac, normal, IVC normal, but a local venous bulge. Why did it happen over here? What was the reason? Again, this is a case where we have a history of deep vein thrombosis. But the GSV is not refluxing, and the patient has a varicose bunch in the thigh. Deep vein venogram and varicogram were planned. The deep vein venograms show absolutely normal veins. When we do a varicogram from these veins, let us see what we see. It is only an isolated bunch becoming varicose. The GSV remains normal, the deep veins remain normal, only this bunch. So why did this bunch happen this way? What went wrong in this particular place? Was there an infection? There was no history of infection. Was there a trauma? There was no history of trauma. So something is happening, and if this is allowed to grow, it could easily, transmit all other tributaries towards the knee joint and lead to phleboarthrosis, maybe something new which you don't know as yet. So, the parked observation, varicograms were performed in the pre-USG era. USG machines and use of Doppler ultrasound shifted the balance towards the non-invasive. That doesn't mean that the cath labs have died. We do use cath labs for deep vein thrombolysis or for arterial procedures and so on. The cath lab is one of the best companion, like Doppler is our stethoscope, and cath lab is probably the most trusted nurse working with us and giving us the best output towards the patient. Many a times people feel that the end is reached, but that may not be true. Interestingly, a paper published in 1987, it narrated that we have known everything what we wanted to know about veins and we did not know anything further. However, every one of us know after 1987, there has been a mammoth progress. Like this morning, we have been listening to various types of lasers and the various frequencies what Shoaib told us, and what Rahul demonstrated, what Sandeep demonstrated. Everyone, when Robbie demonstrated, so many things have coming up and up, so it cannot, but this was a paper published. The use of varicography to identify the source of incompetence in recurrent varicose vein was attempted way back in 1984. But this was way back in 1984 when the ultrasound was not there and their focus was on recurrent varicose veins. Here comes a question. Which vein do we call recurrent? If we call recurrent vein, then the GSV or its branch which was refluxing and we had ligated or burned it out with EVLT or RF, and then again it woke up, then it is a recurrence. But we all as surgeons know that if an appendicitis was there and an appendix was removed, and then if there was a post-appendicectomy pain, the cause was not appendix, there was something else. So these recurrent varicose veins could be something else as a source. Intraosseous phlebography and pelvic phlebography is nothing new. Article in Portuguese and article in French years back were presented. Presently, no abstracts are available. But if you go back to and read the atlas of Professor Wool, he has shown intraosseous venous drainage systems, and he has also shown dilated veins resulting into a dilated foramen into the bone and a chronic pain in the bone, around the joint, in the joint. So dear friends, a lot remains to be understood. A person like Sunil, who dedicated his life and trained so many young surgeons. I think the best we can do for him in his memory is a message which I will soon deliver. These veins, how do we explain this type of veins? It's very, very difficult. There are other veins, we keep on seeing the main trunks which we are looking for, lasering out and this and that, the professional call. Here, these veins, we keep on seeing such type of patients and we go on labeling them that this could be the congenital present veins and this could be this type of veins, but yes, why they are there? What is the reason? This patient, very easy diagnosis. Yes, there is an IVC obstruction, there is something this, something that, the Budd-Chiari syndrome or 1, 2, 3, 4. No, there is no ascites, Budd-Chiari is less likely. Okay, then there is an occluded IVC, yeah, fine. And these are the alternative channels, agreed. These are the commonest channels. But have we ever seen channels also on the back? Where are they going? Why they are seen over here? So this why has to be answered. The pictures on the right side is KT syndrome. Yeah, KT syndrome, very right. But look at the veins. The veins, the way they have dilated. The skin also is giving a cover, not like that of a caterpillar being covered. You can see each and every area. And then there is, yes, there is pigmentation, understood, but look at these veins. How to explain this? Where is the gene? What is the gene modification? And on this side, left side, this is no congenital. This is such a superficial vein running, becoming aneurysmal here. This is a great saphenous vein. It was refluxing in its entire length right up to the ankle joint, causing this discoloration. And this was causing such a severe reflux and volume reflux that patient used to remain in tachycardia. When we dealt with this, after doing, we did a deep venous study, everything was okay, and then we treated all this thing, the tachycardia component went off. Tachycardia with occasional extra-systems. So there is a message to the young generation. Look, I am at the other end of life. I don't say I'm going to die tomorrow, but then I am towards the setting sun. I have lesser number of years to live than most of the young people who are sitting over here have. That doesn't mean I should stop working, I should continue work. Yes, and I would, as long as my body permits. I would go on trekking also, I would go on writing books also. Like Sanjay mentioned, yes, I've written one book on diabetes, and the title is Diabetes a Friend. Don't run away from diabetes. There's another book which I've written for the final MBBS students, because we are all getting far away from the clinical knowledge. We just want to finish off, no mugging up. Simple, ready reckoner, 94 pages. It is published already. The third book I have written is O Musafir Tu Jayega Kaha Sanjay. It is already there. It's available on Amazon as well as it's available on net, and it is very much there. What a journey called life can teach you. That is the motto right now behind writing that book. I wish I could share. I think President Bedi is carrying a copy with him, and I'm very proud and happy to share that the foreword of that book, Musafir, has been written by none other than Professor Ramakrishna Pinjala, one of our members. So dear friends, cycle of observe, think, observe does not take a couple of years to a new thought. It takes a couple of decades. So what? Continue thinking and observing. It does not cost to think and observe. It may reward. And my message to the young generation, the budding vascular surgeons, the growing vascular surgeons, the thoughtful vascular surgeons, and a message as if it is coming from Sunil to all of you, dear friends, is we do conduct studies, but we have a habit of writing our results are comparable to the Western standards. Why? Why can't we come out of that? Say these are our results. Let it go to observation. Let it be rejected or accepted. But we have our sincere results that this is what we observe and this is what we think. So someone sometimes thought that there is something in these oranges which takes away my cough pain. And then that thought went on and on and on and on, and then diosmin and flavonoid and micronutrients, etc., all of you know. So why? Why from these oranges? But there must be an observation. Our country has millions of such observations written in our books. All sorts of, I'm not going to quote Upanishads or Ayurveda or anything. No, they're written millions of them. We can search something. Since 3 years, I've stopped talking Rama. I speak Ram. I don't speak Krishna. I speak Krishna. I don't speak yoga. I speak yoga sanam, or it is yoga. Why do we want to follow others? We have our own. So my dear friends, these are the most challenging veins. The spider veins, the source unknown, the thought process to be evoked in yourself, the observations to come together, to study and find out something new and present it to the world. I think if we do that, that would be the best we could do for our friend who departed from us so early.
Thank you, sir. Shall we give it up for Dr. Devendra B. Dekiwadia? To honor him, we have the presentation of the plaque of honor, the medal, the citation, the certificate, and the shawl. I now request Dr. Indra Agarwal to honor Dr. Dekiwadia, and on behalf of Dr. Devendra, may I request Dr. Harinder Singh Bedi to receive the presentations.
Can we have a standing ovation?
Yes.
Standing ovation.
Can I request the delegates to please stand, and we will have a standing ovation for Dr. Sunil Agarwal's oration. Thank you all. We'll continue to applaud as the presentations are done. The plaque of honor. The plaque of honor in memory of Dr. Sunil Agarwal, presented to Dr. Devendra P. Dekiwadia. The medal of honor. The shawl, the certificate, and finally, the citation. The citation of the first Dr. Sunil Agarwal oration. Thank you, Dr. Indra and Dr. Harinder Singh Bedi.
Thank you very much. Thank you very much. I'm delighted. I'm honored. And I thank all of you from my heart. Thanks a lot.
Thank you, Dr. Dekiwadia. I hope you can hear us.
Yes, I can.
Yes, we have overwhelmingly enjoyed your talk. It has been most encouraging and most inspiring for both young and old. Thank you very much. Goodbye.
Dr. Sunil Agarwal was known as the doyen of vascular surgery, a great academician, a passionate teacher, but more than anything, he was a loving husband and father. May I now call upon Dr. Indra Agarwal to represent her family in giving the response to this first Dr. Sunil Agarwal oration established by the family and the Venus Association of India. Over to you, ma'am.
Good morning, everyone. At the outset, I'd like to thank the Venus Association of India for responding to our request to set up this oration in the memory of our dear Sunil, whom we lost so suddenly and tragically. This is just a small way of remembering him and honoring him and showing the respect that we had for him and for what he meant to many of us who are gathered here. To some, he was an honorable colleague. To others, he was a revered teacher, mentor, and guide. To others, he was a faithful friend. And to us, in the family, he was our pride. But above all this, to his patients, he was a beacon of hope. This was shown in the way he looked after them with empathy, kindness, dedication, compassion, and true selflessness. Sunil had very humble beginnings in a small town of Saharanpur in UP, but he got the best education that any child could dream of, having graduated from the Doon School in Dehradun in the north, and then studying in the Christian Medical College, Vellore in south. And thanks to the farsightedness of his father, who valued good education above everything else, he was instilled with qualities of benevolence, kindness, and generosity, which he learned very early in his life. And the way he lived his life thereafter is a testimony to this. In spite of being blessed and gifted, Sunil lived a very simple and humble life with very few needs for himself. But he was always there for a shoulder to cry on. He was always there to give simple and practical advice to anybody who asked for it. His clarity of thought was always admirable. His righteousness and forthrightness was always very evident in the way he lived his life and dealt with various situations that he faced. I'm sure many of you have your own stories to tell, your own experiences to share. Sunil was an inspiration to many. For us as a family, he was our star. But to many of you over here, we have lost our star, but many of you have actually, in the surgical fraternity, probably lost a lot more. We hope that through this oration, which has been instituted by us, by his proud parents, he will live on. The principles with which he lived in life will be an example to many young budding surgeons, who probably many of whom are sitting here. I would also like to take this opportunity to thank the vascular unit at CMC, who have overwhelmed me and the family with their love and regard that they have shown us. I'm sure you will take the unit and the department to greater heights, and I'm sure make Sunil proud. Thank you very much for giving us this opportunity to being with you here today. Thank you.
Thank you, ma'am. May I now call upon Dr. Deepak Selvaraj, Professor and Head of Vascular Surgery and the Vice President of VAI, to propose the vote of thanks.
It's been an honor and privilege to come and stand here and the first Sunil Agarwal oration for my beloved teacher. He has been a great source of inspiration for me personally, how to conduct myself with integrity and be very straight in whatever we do. Call a spade, he used to tell us. like the rest of the Venus Association of India, all of us, we really miss him. I thank the Venus Association of India for giving us this opportunity, as well as I thank the family, Dr. Indra, Appa and Amma, and their sisters and brothers, the sons, for giving Venus Association of India the honor to have an oration. It will be an uphill task for many of us to reach the status of Sunil Agarwal as a teacher, but that is what we will all have to aim. As youngsters, the future awaits us. All of us have to be good teachers and transfer the knowledge to the next generation. Like Dr. Dekiwadia said, think, observe, and innovate. And always question yourself, question your failures, and come up with new ideas, new theories, make friends, travel, have a laugh, enjoy your meetings. Life is more than just academics. And this is what Dr. Sunil taught us. On behalf of all of us, I thank you all for coming here for this oration. And on behalf of the Governing Council and the President, I thank you all again. We will now continue with the next session.
Once again, thank you to all our dignitaries who joined us on the stage. Thank you to Dr. Devendra Dekiwadia, and thank you to the session's MC, Ms. Sheila, for taking us through the session. We'd like to move forward and take you through another session, and the chairperson for the next session, which is setting up a vein clinic, is Dr. Roy Varghese and Dr. Gulshan Jeet Singh. May we have both of you on the stage, please?
And say a master of ceremony. Parani.
Ladies and gentlemen, thank you so much for your patience so far. I'd like to request all of you to kindly be seated. We would like to continue with our next session, and we have our chairpersons joining us for this session. Mic is right here.
In this session, we are going to have two talks. The first talk is setting up of a vein clinic. Now I invite Dr. Deepak Chalviraj for presentation. The topic is setting up of a vein clinic.
Meanwhile, requesting all of you to kindly be seated. We will have the lunch break after this session, and we will make announcements accordingly. Over to the speaker.
What do they control? Good afternoon, everybody. So as we were trying to set up the talks for this conference, we thought we should have a very light talk after the oration and before lunch. And so Sanjay and me, we decided we'll have something which is very different from academics and which will enthuse some interest, hopefully. So today my talk is on a one-stop vein clinic. And this has been something that we've been thinking about, and we started doing it at Vellore. So I call it the Vellore model. And I would like to, as I go through the slides, I will tell you how we actually started doing this and how we established our vein clinic at Vellore. So the existing systems that we have in all our hospitals and clinics, we don't have any referral systems in India. It's not like the NHS. We have a very crowded outpatient clinic and super waiting times. So patients just come. They just decide to come, so they come. So they just come here and they are really unprepared for what they have come there for. They don't know that they have to wait. Sometimes they don't bring anything to eat. They have got children as well. And many of them are hospital hoppers. They go to a hospital and then they meet a doctor there who says something, and then they're not very convinced, and then their brother says, hey, I know this doctor is very good, go and meet him. So they go to another hospital. So they just keep hopping from one hospital to another. It's not a very good system that we have in our country. So number of visits before any intervention. We have at least 3 visits. So we did a small study at Vellore, and the quality control team actually, we have a QMC team that actually did this study, and they interviewed all these patients who came to the outpatient clinic, and they said the minimum number of times they've had to come to a hospital after the first visit is almost 3. So that is not a very efficient system at all. So the first visit is actually a feeler. The second visit is with a kith and kin after discussion at home, and he has to come for a third visit for an ultrasound scan, and finally decides on the date of surgery. So what happened during the pandemic? I call it the corona conversion. The patients became smarter, the smart patients. They became internet professors because they had to stay at home. They couldn't get out of the house. And they started having net-based second opinions. And there was a growing acceptance to telemedicine. And in Vellore, we actually initiated something called the eMeds, which is the electronic medical distribution system, where we actually do a prescription on our computers, and somehow we figured a way where the medicine reaches the patient all over the country, right from Arunachal Pradesh to Kanyakumari. We used India Post to do that. And then we also we established intelligent call centers, which were actually helping us in this whole scenario. So how does this work? How does the one-stop vein clinic work? So you need a reception, you need a good, smart call center, you need to have a proper triage team, and you have to have excellent vascular nurses, specialist vascular nurses who can actually do many of your work, including scans. You need a doctor, but he's not the most important person in this whole thing. And you need a small theater team and somebody to do a post-op monitoring, and then you discharge the patient. So all this happens in one day. Patient comes in, you do all these things, and he goes off in the evening. So central to all these things is the call center. So the call center has to have 3 or 4 people with some computers. I'll tell you how we actually figured out the call center. They have to liaise with the patients. They collect data like reports, scans, and pictures. So all this is done by the call center people using a computer, a terminal, and a web-based server. And they have to fix telemed appointments, fix direct appointments as well, and track emed queries, because you're going to see a patient with venous ulcer and going to give him a 4-layer dressing, and then it has to go and reach the patient, and liaise with the doctor, pharmacy, patient, and the courier service. In this case, in CMC, we use the India Post. So at least you need to have 4 computers or workstations, 1 supervisor, 3 personals, and 3 personals, a LAN connection, scan, fax, telephone, WhatsApp, and chatbots really have changed the way we liaise with patients. So that's how it whole works. You have the call center at the center, the doctor's order, the patient. This is how our eMeds works. Then they liaise with the patients, they liaise with the payment portal, the pharmacy, and the courier service. So triage, next thing is the triage. As soon as the patient comes in, you have the reception followed by the triage. And the triage has to be, again, nurse-led. They take a brief history, brief examination of the legs, including the pulses, and dressings may need removal. And then the patient goes to a vascular lab. You have, again, a specialist nurse or a vascular technician there who does the ankle brachial pressure index, TCPO2s, air plethysmography, and duplex scans. So then, by the time the patient reaches the doctor, most of the work is done, and then you have a guy sitting there who calls him the specialist, and all he has to do is to convince the patient to undergo a certain procedure. And all the procedures in these one-stop vein clinics is done under local anesthesia, and patients will be discharged on the same day. So you need to have after you see the patient, you need to have a theater. We should have a very friendly atmosphere, because the patient is walking in and he's going into theater, and you have to explain the procedure properly. And please tell the patient that it is not a painless procedure, although there will be some pain. And we have started using more and more non-thermal ablative techniques like glue, which have less pain, and foam sclerotherapies, and we even do microphlebectomies under local anesthesia. So after the procedure, you need to have a post-op monitoring team, and at least 2 hours of monitoring we have. We ambulate the patient, give them adequate compression, and we usually review them after a month, and escape consults can be ordered by teleconsultation if the patient wants to ask any queries before the monthly appointment. And stockings and drugs are distributed by month. If the patient feels happy to have a teleconsultation after a month, we see them, we extend the medication and send the medicines by eMeds, that the electronic medical distribution portal that we have. So you can actually, like Dicky said, you can let your thoughts fly, and you can add these other rooms if you want to. You can have a compression therapy room, which can have at least 4 patients at a time, a multi-chamber compression. You can have people doing manual lymphatic drainage and teaching of drainage techniques, videos, stockings measurements, how to wear a stocking, advised on the best stockings that the patient needs to buy. And you can also expand some more if you can use reflexology. A lot of people just swear by reflexology, naturopathy. We're in India, we've got all these things, so you can include them. Anything to do with legs, Ayurveda, yoga, fish massage, if somebody wants to do that. And so it's basically a one-stop vein clinic, and let your thoughts fly. Patient comes in and goes home very happy. So what are the advantages? It eliminates waiting times, abolishes unnecessary outpatient appointments, it saves time, enhances patient satisfaction, and quality of life can improve. There's a huge cost saving which is possible. But what are the limitations? Some patients may need other department consults like cardiology, medicine, etc., geriatric medicine. And some patients may have complex varicose vein, thrombotic issues which need further evaluation. And sometimes it's very difficult to convince the patient, when he comes in, but he has to come in prepared. And theater facility has to be utilized optimally, otherwise you might run into a loss. And so you need an optimal patient load. And to start off, I would suggest this works well in cities and urban-based clinics. So in conclusion, it's an attractive option. There are very few licensing issues. Specialized vein clinics are the need of the hour. And sometimes it not may be a one-day affair, because for insurance, the insurance patients who have insurance may need to have longer stays. That is an issue which we have to sort out. Thank you so much.
Thank you, Dr. Deepak, for covering the nice topic, the setting up of a vein clinic, specialist vein clinic. And we can have a discussion at the end of the second talk. Now I invite Dr. Sanjay Desai for the topic, formalizing education in venous disease. Dr. Sanjay Desai, please. Thank you.
Thank you, sir. Well, as Deepak said, we thought we'll have some light topics or, well, not really light because